Hello, today I'm going to demonstrate the nursing skill of a blood transfusion. After you've verified your orders and you enter the patient's room, you'll do your hand hygiene and introduce yourself as the RN. You'll want to check the patient, make sure using two identifiers that this is the correct patient on the order. Explain the procedure to them and tell them the risks and the benefits of having a blood transfusion. And they should sign a consent showing informed consent. Then you're going to want to check the IV site for patency. Make sure that this is going to be able to take the blood without any problems. Make sure that the gauge is large enough. It should be, since this is not an emergency transfusion, which would require an 18 gauge, a larger bore angiocath. But this is not an emergency, so this 20 gauge will do. And I'm going to check it for patency now. Cleaning off the port. And checking for patency. The IV site is in good shape. We want to make sure that the patient is completely ready to receive the blood when we get back with it from the lab, because we have 30 minutes in which to start the transfusion. If you think there's going to be a delay after you have brought the blood up, you'll need to return it back to the blood lab. Next, we'll need to get a set of baseline vital signs, because if there's any meaningful change in the baseline, that will alert the nurse that there is a potentially a blood transfusion reaction. First, we're going to use our special tubing. This is Y tubing, has two arms on it. One is going to receive the normal saline that we're going to be transfusing, and the blood will go on the other side. We use normal saline in a blood transfusion because it's compatible with blood. You don't want to use anything else that has anything more in the solution, like dextrose, because that could coagulate the donor's blood. So first we'll want to prime this. We have clamped off previously, clamped off all of these before that, and I'm going to open this up. We'll want to fill up the drip chamber above the filter. We want the blood, when it first starts to come down, to be hitting fluid and not the plastic, which could rupture the blood cells. I'm going to prime this other half of it also while we're doing this. And carefully keeping that intact. I'm going to finish priming all of this. Getting all the air bubbles out. And now I will clean the side again. We're going to let this start to infuse at a slow rate of 75 mLs an hour. This blood tubing has a drip rate of 10. So that means 75 an hour. So we'll divide 75 by 6, and that gives us 12. So I'm going to, 12 will be 6, like one drip every 5 seconds. It's going to be kind of slow. And there we have it. Now that that's infusing, I can go down and get the blood from the lab. When I return with the blood, I'm going to have another healthcare professional check this with me, because one of the most common mistakes in a blood transfusion causing a hemolytic blood transfusion reaction is a clerical error. So between being checked, making sure that this is the right blood with the lab tech, I'm going to check it with another nurse up here. Use whatever your facility's policies are. You're going to want to check to make sure that the donor's blood, B, matches your patient's blood. So we'll check and make sure that this is the right patient, and we'll have the patient ID number for this particular type and cross that they've had done. And we will check that ID number. So his ID number is LO7HCT21, and that should be on the blood band here. And then the donor number should match this with this. And so me and the other nurse will check and make sure that the donor number is the AOK123 and AOK123. We also want to make sure that it is not expired. So take a look and see at what the expiration date is, and also just take a look at the blood and make sure that it doesn't look like there's any bubbles or it isn't discolored. Now that we've done that, we're going to get another full set of vital signs and obtain those and record them. We're going to be getting vital signs for the first 15 minutes every 5 minutes. Now I'm going to clamp off the infusion, normal saline, and I will carefully, to not contaminate the blood, spike this and hang the blood on the other side. We've clamped this off, and now what's going to be infusing is the blood. I'm also going to want this to run at 75. So that will be 6 drops in 30 seconds. And I will adjust this rate to that. Having it start at this slower rate reduces the patient's exposure to this blood until we're assured that there's not going to be a blood transfusion reaction. Once the blood hits the patient, I'm going to begin counting for the 5 minutes, timing the 5 minutes until the first vital sign that I get. So after 5 minutes, I'm going to get a set of vital signs and record them. I will do that again for every 5 minutes for another 15 minutes. I will remain with the patient the entire time. And then after that, I will come in every 15 minutes for the first hour and get another set of vital signs, checking on the patient, making sure they're not having any reaction, making sure they're not having any difficulty breathing, that their blood pressure hasn't dropped, that their heart rate hasn't gone up, they don't have any itching or rashes or any changing condition since the blood transfusion started. And then after that first hour, I will come back in every 30 minutes, as long as everything's going well, and get another set of vital signs. Every time I come in to get these vital signs, I'm going to check and make sure that the IV site is clear and that the patient is still comfortable. If it does infiltrate during the infusion, you can stop the transfusion, make another site, and restart the transfusion. You'll have to figure out when you're doing that, will this still make the blood transfusion go in over 4 hours from the time that we picked it up from the blood bank? It must go in over 4 hours. Or we'll have to stop the transfusion and notify the doctor that the complete transfusion wasn't given. So as we come back, checking on them regularly, they could start to go into fluid overload. So if they do that, you'll be assessing them, listening to their lungs, notify the doctor, and you might get an order for some diuretics. So now, after the first 15 minutes, you can change the rate. You can increase the rate. And because this is at 300 mLs of blood, and I would like this to go in over 2 hours. Get this in as fast as possible, as safe as possible. And so if it's 300 mLs, then I can put it in at 150. So I'm going to change this rate from 75 mLs per hour to 150 mLs per hour, and that will double the rate. And so I'm going to increase this from being 6 drips in 30 seconds to 12 drips, because 150 divided by 6 is 25. So 25 drips in the minute. That will be, and I can increase that. And let the transfusion continue. While they are getting a blood transfusion, if they do have another order for another medication, you will not give medication through the same tubing as they're getting their blood transfusion. That could increase the potential for contamination and also for a interaction between the medication and the donor's blood. You're going to continue checking on them every 30 minutes and until the transfusion is complete. Once the transfusion is complete, you will clamp off all of the tubing, put all of the bags into a biohazard bag, and dispose of them per your facility's policy. For an hour after the transfusion is complete, you're going to want to continue to check on the patients and get their vital signs 2 more times, every 30 minutes, until you know that they are not having any reaction. Let me make sure I have this clamped down. And then I will dispose of this properly. To make sure that the IV is good, I will clean this off again. And flush it.